Thank you very much. I'm going to talk a little bit about cardiotoxicities of cancer in childhood cancer survivors. And part of what we've been studying for the last 3 decades has been as we've had tremendous advances in treating childhood cancer with very high rates of 5-year event-free survival. It's enabled us to really focus on a lot of the toxicities and late effects. And as we've approached this, we've taken an understanding for these first generation of survivors of childhood cancer to focus on 3 things. First, we felt it was very important to understand the course. So as I approached this talk, I'm going to show you that, by understanding how you get potential injury, how that leads to maladaptive changes, how that can progress to cardiomyopathy, eventually for some patients may lead to clinical symptoms such as heart failure or arrhythmias, and can result in some cases improvements, continuing morbidity, pump failure leading to death, sudden death, or need for transplant or destination cardiac therapy. Then it enables you to determine, once you understand that course, what are the risk factors for this? Who are particularly at risk? And I'll go over that a little bit more here as well. The third thing that we really focused on was there's hundreds of biomarkers we can measure during therapy to say whether somebody's heart has been having changes. But there's surprisingly few of those that have been validated as surrogate endpoints against clinically significant disease later. So this is, again, down here, the third area that we focused on. And as we go through this, why is this so important? Because when we look at these red numbers, 1, 2, 3, 4, 5, we've tried to focus on preventive strategies. Preventive strategies are progressively less effective as those numbers increase. We're able to do primary prevention at number 1. Secondary prevention is possible at numbers 2, 3, and 4. If we're looking at not preventing, but if we have established heart toxicity, how about treatment? Well, we find there's a greater impact with higher numbers, such as 4 and 5, but longer effects with lower numbers. And treatment's possible even at 4 and 5 to reduce sequelae. And when we look at this, 25, 30 years ago, successful treatment of childhood cancer was defined by 5-year event-free survival. And since the early 1990s, my colleagues and I have been pushing the concept that a new paradigm, that the successful treatment of cancer is determined by the balance between oncologic efficacy and toxicity and late effects, as measured by really the balance, by the quality of life for a patient and their family over a lifespan. And that's really how we approach this. And, this is an example for children with the most common type of cancer between 2 and 18 years of age, childhood acute lymphoblastic leukemia. And what you see here is in the late 1960s, only about 4% had 5-year event-free survival. When we started doing cooperative group trials with multi-agent chemotherapy, we had 40, 50%, and it's steadily increased where some of the best protocols for high-risk ALL have 85, 90% 5-year event-free survival. So this just was a consortium that I've been involved with. Most of my career was spent at Dana-Farber Cancer Institute and Harvard Medical School, and these are the results as we've treated patients. Now, in the United States, because we've had so many survivors of childhood cancer, we've been able to cohort them, follow them longitudinally, so we can learn from this first generation of survivors. And so our National Cancer Institute has supported a study of nearly 30,000 survivors of childhood cancer called the CCSS study, or Childhood Cancer Survivor Study. And what that's shown us is that these first generations, there are common late effects, and there's relative morbidity 30 years after childhood cancer treatment. And in this slide, this is the relative risk of these survivors versus sibling controls. And it's an important concept because if you're managing a patient that's a survivor, just as we just heard in the last wonderful talk, it's not just the heart. The kidney may have toxicity. We can see neurocognitive. You know, treating heart failure when somebody has an underlying treatable cardiomyopathy from an endocrinopathy it's important to know that because you can really have a more successful outcome, perhaps. So, you know, in terms of long-term survivors, in terms of heart dysfunction, what I'm going to go over is coronary artery disease, relative risk of more than 10, heart failure, relative risk of more than 15, stroke, relative risk of 9. And when we look at it, we see increases in morbidity from the same CCSS study. If we look at hypertension, dyslipidemia, diabetes, they're all higher in survivors than in controls. The sibling controls are in yellow here. And it's not like they're minimized and going down with time. They're actually going up. When we look at more specific clinical endpoints of coronary artery disease and A, valvular heart disease, and B, arrhythmias and heart failure, we see that it continues to go up, and this is in relation to radiotherapy having been given. I'm going to focus in this talk more on anthracycline. We've done a lot as have our colleagues in radiation, but in the interest of time, I just wanted to put this in there that, again, we frequently will focus on just one therapy, but none of our children receive just one therapy, and they all have potential toxicities, and they may be more than additive. This is work from a cohort throughout France and Great Britain of childhood cancer survivors with 27 years of average follow-up after diagnosis of childhood cancer, with over 86,000 patient years of follow-up. And in A on the left, it's now, I was just showing you before morbidity, this is actually mortality data, and mortality against the general population in France and Great Britain. And what you see is cardiovascular deaths observed versus expected continue to go up even decades after exposure to cardiotoxic therapy has ended. And it's going up at a really an exponential pace. On the right, it's cardiac death. And these were the most significant increased relative risk causes of death in that study. And this has been seen in cohorts around the world. So this is some work that we've done in terms of looking at left ventricular contractility, the health of heart muscle cells, in children that were treated for acute lymphoblastic leukemia, starting at 0.0 here. The red dashed line is at the end of doxorubicin therapy. And here, this is where we would expect normal contractility of the heart. And so what this says is at the end of treatment with doxorubicin, these children who started out with normal hearts have significantly unhealthy heart muscle. In fact, they have DCM up there, stands for a dilated cardiomyopathy as a group, statistically significant, largely asymptomatic. As they come off of therapy, during the first 5 or 6 years, their heart recovers. It becomes normal in terms of contractility. There were more than a dozen papers published in the literature saying not a problem because it's reversible. That's where, again, it becomes important to be able to follow the course of these patients, because what we see is that the long-term follow-up is essential to see if an early doxorubicin hit results in late cardiotoxicity associated with progressive cardiovascular morbidity and mortality. And we find that those that were the most affected during therapy, as they then go through puberty, as the heart is asked to grow and become larger, there's loss of heart muscle cells, and we see that the health of the remaining heart muscle cells gets worse, and this is with 14, 15 years of follow-up. Their type of cardiomyopathy now is a restrictive cardiomyopathy. This means that they have insufficient amount of remaining heart muscle for the size of their body, and their heart is too small for their body. Now this is 10, 15 years out in really large cohort studies, United Kingdom, France, Netherlands, the Nordic countries, United States. They're almost superimposable, very consistent. In 20 years, 30 years, large numbers of patients, very significant increases in cardiac morbidity and mortality. And at least in the United States, it's still an issue. There's more than 50% of the survivors of childhood cancer have been treated with anthracycline, and we still use it widely today. Now, one of the things that we did find is when we looked at 8 years after treatment with anthracyclines for childhood leukemia or osteogenic sarcoma, we found there was impaired heart function. The ejection fraction and fractional shortening were depressed. We found in our multivariable analyses this was related to two different pathways. In blue on the left is something that we also see in adults, but we also saw in this childhood cancer cohort, that there was a significant relation. Those that had intrinsic depressed contractility, unhealthy heart muscle, had depressed function. And we found that in our multivariable analyses, this was significantly related to girls being more affected than boys, higher cumulative doses being more likely to lead to unhealthy heart muscle and driving heart function down. But one of the things that we saw on the right was that in growing children, even if the health of the remaining heart muscle was normal, their afterload or stress on the wall of their heart could be dramatically increased because the walls were thinner than normal. And when there was a loss of heart muscle, if I'm the left ventricle and there's a rubber band between my fingers here and it's loose, there's not much stress on the walls of my heart. If I stretch that and that rubber band becomes thinner, that's this wall thickness becoming thinner, there's more stress on my fingers. So that is another way that it drives heart function down. And so what we found there was that in the children that were the youngest, where their 60-gram left ventricle had to become a 300-gram left ventricle just by the muscle cells becoming larger, the Doxorubicin killed enough heart muscle that they could only get so large, and it was an inadequate number of heart muscle cells. Under the microscope, the heart muscle cells look quite large, but there's just not enough of them. And so that means that the wall thickness for the size of the body is reduced, the stress on the walls of the heart are increased, and it drives heart function down. And these effects are not minor. So if I was seeing a child 8 years after treatment of childhood cancer with anthracycline in my clinic, and if that child had gotten, let's say, 450 milligram per meter squared, if it was a boy, there'd maybe be a probability of about 10% having an unhealthy heart muscle. But if it was a girl, it was maybe 40, 50%. And now, what we see is when we follow those same children that I just showed you that we were looking at 12, 13 years, we've brought them back now. We continue to follow them. It's really a challenge, but we have up to 40 years of follow-up, an average of about 30 years of follow-up. And what we see here is that about 15 years after treatment, that's where it transitions from this dilated to this restrictive cardiomyopathy. And we, just to be cute, we call it Grinch syndrome from the Dr. Seuss book, with where the heart, you may remember it, was too small for the size of the body. But unlike the Grinch, we don't yet know how to make that heart become a more normal size. So the way we've gone about this well, we also see that it relates to the dose, but the way we've gone about it is we try to say, well, we're cardiologists, we do a lot of clinical trials, we have a lot of medicines, let's use an ACE inhibitor, let's use an enalapril. So this was a study where we brought a bunch of childhood cancer survivors that were treated with anthracyclines years earlier. This is normal heart function. This is the equivalent of an ejection fraction. This is fractional shortening. But here, fractional shortening 3 years before we started enalapril was 4 standard deviations below the red line, which is normal. Over those 3 years, it got progressively worse. This was, we started enalapril when the shortening fraction was about 19%. That's an ejection fraction of about 38%. We found that there was a significant early improvement in heart function. We said, that's terrific. Maybe we can make a difference. But what we found was we bought time. By 6 years, it was no longer significant. We had bought 6 to 10 years. These are for people that were had asymptomatic left ventricular dysfunction. Those where we waited till they developed heart failure, we saw a similar early improvement, almost exactly the same. But by 3 to 6 years, 100% either needed a heart transplant or died a cardiac death. So that prompted us to say we should really look at either convincing our oncology colleagues not to use these drugs, which they said we need to use them, or to try to prevent this, because if you wait till it happens, we buy time, but we don't actually truly prevent. So one of the things that our oncology colleagues said was that perhaps if we give the doxorubicin in a gentler, kinder way, if we do continuous infusion, if we bring these children in every 3 weeks, and instead of giving it as a bolus over less than an hour, we will give it over 48 hours times 12 cycles, so an extra month in the hospital for these kids. The thought was that it would lead to a reduced peak serum level of doxorubicin, and there would be less cardiac injury. And so we did that. We did a randomized controlled trial in the field of pediatric cardiology that I'm in. It's probably the longest period of blinding we've ever done in a clinical trial. We were blinded over 15 years, and when we were unblinded here, this is what we found. This is fractional shortening, equivalent of an ejection fraction before at diagnosis, before they received any doxorubicin. Heart function was not different between those that were randomized to get it by bolus and those that got it by continuous infusion. And it was above normal. They were hyperdynamic. Sadly, an average of 8 years after treatment. Heart function was depressed in both groups. There was no protection here by continuous. Wall thickness, again, there was loss of heart muscle. They were thinner than they should be in both arms, no protection. Loss of heart mass was present in both, no protection, and the hearts were dilated in both. And why am I bringing this up? Because at least in the United States, this made sense. Clinical trials did not occur. This was written into many, many protocols. Still is, actually, for the purpose of cardioprotection. Cost about an extra almost $1 billion a year. An extra month in the hospital for a 4-year-old, increased mucositis, and increased thromboembolic events. So sometimes you got to do the studies. So then it prompted us to say, well, we had an animal model in the rat where we could test. We tested about 200 different things to protect against anthracycline. One that was promising was something called Dexrazoxane, which was just brought up in the last talk. What happens here is doxorubicin disrupts the normal catalytic cycle of topoisomerase 2 beta. It causes DNA double-stranded breaks. It further leads to defective mitochondrial biogenesis. And it results in an increase in reactive oxygen species. And the myocytes develop disarray and vacuoles develop. And this dexrazoxane binds to topoisomerase 2 beta, and it prevents anthracycline binding. It also binds to iron. It's like EDTA. It chelates it. And when we tested this, in the interest of time, I'm just going to skip a couple of these. In our rat model, we found that with 12 doses, if they didn't get it, the hearts, even in the back of the room, you wouldn't want your heart to look like this. And when we did give it, it looked pretty normal. So that let us bring this into kids. And the dexrazoxane did not protect the heart. And when we were unblinded by our data safety monitoring board, these are the two arms. The blue did not get dexrazoxane. The yellow got dexrazoxane before every dose. This on the y-axis is a measure of myocardial injury, dead and dying heart muscle, cardiac troponin T in the serum. So that was really very protective. Same study when we look 5 years after treatment. There was, in the girls, there was the two arms, exact same study. There was really almost complete protection in terms of dilation of the heart, in terms of having walls that were too thin, depressed heart function, and most importantly, when we looked at remodeling of the heart, pathologic remodeling, which on the top is an example after a heart attack when the wall's thin and they dilate, it completely blocked that from happening in the girls. We've done a number of other clinical studies throughout the United States through the Children's Oncology Group using this. Every one of them, it's been protective. And in the interest of time, I think that what I wanted to conclude here is that cardiotoxicity associated with cancer therapies, it can be pervasive, it can be persistent, it can be progressive, and if you don't look, you don't know. You can miss it clinically. And cardiovascular-related health burden seems to be increasing as this expanding population ages. Didn't have time to get into some of the genetic components, but genetic, environmental, and temporal factors interact to cause toxicity and identify high-risk groups for safer treatment options and targeted interventions. We showed that continuous infusion really was not effective. Enalapril delayed it, but didn't prevent it. And dexrazoxane was cardioprotective. And the same way we use multi-agent chemotherapy, the mechanisms where the heart gets damaged are multi-mechanism. So we've been testing multi-agent cardioprotect, and we find that that makes a big difference. So thank you.